Hello everybody and welcome back to this lecture that will be covering the topic of biological integration. After having seen the aesthetic and the functional integration, now we try to focus on the biological integration. Of course, we will talk about two preparations and also impressions, technique and material. So let me start with two preparations to talk about some principle on two preparation. First of all, minimize the tooth structure removal. We try to be as less aggressive as possible to maintain tooth structure underneath, to avoid to injure the pulp, to have any problem of devitalization. That we want to keep the vitality of all our abutments, maximize the resistance of laterally directed forces. That is what happens in the mouth when you chew, of course, and minimize also the plaque accumulation. With the ceramic is well done, well refined, you can have the great margins on the area or cervical area without having any inflammation at all. So let me check with you what are the difference between my preparation in 88, so long time ago, and that's in 208. So you see that we have the chance to see that we had a lot of devitalization on the traditional and conventional solution, and the post-encore and even crown surgical crown antennae procedure that you cannot see here, but is done already in this case. On the other situation in 208, we had a much more conservative approach. You can still see some occlusal setup in order to see that the anatomy of the occlusion is still there. We can keep a lot of enamel, and that is really innovative. Today, we are even more conservative. That is another example in 2018. So 30 years far away from the initial one that we have done a lot of post and core. Now we can keep vitality, incredibly healthy situation that we can keep as it is. We can bond our restoration on enamel mostly. If you look also at the lower arch, you could understand that the right and left quadrants are really not prepared at all. So we are really minimally invasive, and that is what we would like to achieve today. So let me do the difference between the conventional tooth preparation and the innovative one. So the concern are, how much tooth substance should be removed? That's the first question. Should the preparation go all around the abutment, 360 degrees? What kind of convergence you have it? So the path of insertion should be with the parallelism of the of the axis wall. It should be 60 degrees as it was said in the past, or now it can be different. What kind of margin you want to select it? So the feature of conventional are this following. First of all, we do crowns. That's it, the conventional classic area of preparation. So you do crowns. So you go 360 degrees. Should be a kind of shaped as a truncate cone. Is a cone that is truncate because of course it's cut in the. We have the taper that has to be about 2 to 6 degrees, and actually is really not, is very, very parallel actually, and having a minimum height of the walls, axial walls of 3-4 millimeters, and for the porcelain fused to metal selection that is normally related to this kind of preparation, you have a clearance of 1.2, 1.5 on the axial walls, a 1.5, 2 millimeters on the occlusal one. So it will be a really quite big preparation, not conservative at all. And normally we have the kind of margin that are quite sharp, like chamfer, heavy chamfer, or shoulder. And that is the characteristics of conventional. What about innovative? The feature of innovative is the following: less invasive as possible. That's the first step. We should keep as much enamel we could. That is really imperative if you then want to achieve this kind of bonding procedure. That is, of course, a very safe procedure to keep the restoration in place for a long time. So you can bond the restoration. It can be the design you wanted. Can be complete, 360 degrees. Can be partial. Can be only inlay, veneer, full veneer, buccal occlusal veneers, as you like it. The design is up to you. So let me explain what happened in the past years. The preparation you see there are on the 90s maybe. It's quite being chamfer or under the shoulder. On the 2000, we started to prepare less because we have developed a new material on ceramic restorations that they didn't need so much space anymore. So we started to decrease the intensity and the invasiveness of our preparation. Today, even though you do a 360 degrees design of preparation, we have just removed a little bit the undercuts, but we keep enamel, in most of the cases, 100%. So we just remove the undercuts. We have prepared very minimal. We don't prepare more than that. So that's the transformation that we had in the last years. There is an interesting article already published quite a long time ago that was saying that if you prepare for crown, you remove much more substance than veneer or partial veneer, like you see here. That was an article by Edelhoff. It was very interesting. So why to choose the conventional or the innovative? Depends on what? That's the question that you can ask yourself. As we said, depending on the configuration of the existing two preparation. Sometimes you have to redo all the restorations. It's important to understand that because you cannot do differently than what you do. So preparing conventionally. So the amount and the configuration of the two structure that remain under the restoration. The type of the restoration you want to use. If you want to use a metal ceramic, you need space for sure. So design of the prosthetic solution, if it's like a single restoration or a bridge. With a bridge, it will be complicated to have a very innovative solution because you have to remove the disparallel between the long axis. And not last but not least, the training and experience of the dentist. That will be very important. If you talk to a dentist that is already very expert, like me, it will be more complicated to convince this kind of dentist to move from traditional to innovative, because it's traditionally done in one way. And we are already prepared and experienced on this kind of field. But of course, that should be a new stimulus in order to have to change our mind and to try to do different if we have the chance to do it, like innovative if you have the chance to keep enamel, for example. So let me go to this kind of clinical situation, the amount and configuration of existing two preparation. So you see on the left side, before I prepare the teeth and then after my preparation. What you could see that are very dark and with a light teeth already present there. But even though they use metal ceramic, they had the chance to see that the marginal area were not prepared at all. Was like a very conical preparation with no space on the cervical and much more space on the incisal third. So of course what we have done, re-preparing the teeth on the marginal area to cover the darkness and just to have the chance to create the best kind of result in terms of aesthetic. And putting the preparation in an intracircular position in order to not see this area. That is what happened in this case. So we cannot, of course, choose any innovative preparation. We have to stay unconventional, but you can improve the conventional preparation that was made by another dentist with your new preparation that we did. Okay, that is still, we are in the conventional area. We cannot talk about innovative in this case, of course, not at all. So what about minimally invasive preparation and which margin design could we choose? Which one is the innovative? Only the one that is on your left. On the other margin design, you have to really understand that you have prepared the teeth very much. Maybe for the reason we have seen already, because there was already the vitalized teeth. But the only one that is still conservative is the left one, that is like a kind of feather edge design. So, of course, when you have a discoloration of the teeth, you need to prepare more. You cannot keep any kind of feather edge like you can do in a natural color. In discolored, you can see on the right side, you can see that you have prepared more. You have a kind of, how do you say, a kind of light chamfer design, like this. So here, not discolored, is like feather edge. In this one that is discolored, we have a light chamfer design, because you want to cover the color that you have underneath. So another case in which we had this kind of initial solution with the ceramics, you can see some grayness, especially on the right upper central incisor, but also on the left one. And you see that there is a kind of differences in terms of color. Marked discoloration on the central, right one, less discoloration on the left one. So that's the reason why, being both of them devitalized, that's a case of more than 20 years ago, of course, but anyway, being devitalized, we have the chance to see that we have more preparation on the central incisor that is discolored than the other one that is not discolored. At the same time, you can see also there is also another preparation that has nothing to do with the traditional, that is innovative, is the preparation for veneer that was prepared, in this case, on the lateral incisor. It's just an enamel 100%. So you see the thickness maybe is a 1.8 or even 2 millimeters. On the back side of the central incisor that is discolored is much less, like 1.2 on the other central incisor. In this case, you can match maybe the same color, the same translucency and opacity of the material that you put over, even differentiating the thickness of the preparation. Also, the design of the prosthetic solution can be a kind of problem for the dentist, because if you have to do a bridge, like in the left case, you have to splinter restoration, central to cuspid. We should be sure that the distal part of the cuspid and the distal part and the mesial part of the central incisor are parallel each other. So it's not easy to find this kind of parallelism between the distal part of the cuspid, this one, and the mesial part of the central incisor on the right side. They normally are disparallel, and that's the reason why we should prepare a little bit more. And even though you want to be innovative, you cannot save so much to structure and keep enamel in most of cases. So it will be very complicated to keep vitality is okay, but what about the enamel presence? It will be very complicated to keep it. What is much easier if you go to single restoration. You have another problem of this parallelism between the two different abutments, not close each other, but we have just single restoration, and that can be done in the proper way. You can be innovative, you can prepare almost nothing like you did. So finally, when the conventional and when the innovative. Conventional, the presence of traditional preparation already made by the previous dentist. So we cannot do anything else than maybe optimize the parallelism between the two long axes, but nothing more. The use of porcelain fused to metal restoration that oblige you in some way to be conventional. We cannot do differently. You have to prepare quite a lot because you have to cover the metal with opaque dentin and then with enamel. So it will be very complicated to have a thinner thickness than 1.2, 1.5. And then when conventional, when you do bridges, again, we cannot hope to really be parallel without sacrificing some distal part of one tooth and mesial part on the other one. So it will be very complicated to keep enamel in this case. It will be much more aggressive than could be. And then also marked discoloration. That will be another case in which you use conventional tooth preparation. Mainly, the darkness is related to the vitalized tooth. So it means that you don't take a risk to injure the pulp. In this case, normally you have already the vitalized teeth on your side. So that's the reason why you can prepare more without any problem. Just the problem should be keep, please, the ferrule effect. That is the most important step. So to have the height of the abutment that is enough in terms of value. So when innovative, none of the previous conditions exist. So you have not removed an old crown, you have not the vitalized tooth, you have not the marked discoloration tooth. In this case, of course, you can perform in the best way the minimally invasive dentistry. It means preparing almost nothing, as you can see next. So that's the difference between innovative and conventional. So, as we said before, the clinician's training and experience. I believe that the clinician has to be trained to perform innovative preparation design, as he just follow all the procedure to save as much enamel and tooth structure as possible. So we have the chance to use also some silicone index in order to see how much thickness of preparation we have removed. And that is a very important step. Should be done for every teeth in order to be sure that we don't remove too much and to keep enamel as much as we could. You can see very moderate prep. You can see also that with this kind of matrix, you can understand the thickness of the restorations and the preparation as first. That is very nice in this case. Seems to be a little bit less in this middle incisal third than the cervical. So maybe you can improve a little bit. You can modify a little bit. Okay. Now the occlusal view. So we have additive contour for porcelain veneers. I would like to now talk about veneers, preparation of veneers. Why I'm doing? Because talking about the biological integration, that is the chapter of this lecture, that is the topic of this lecture. Normally when you talk about the biological integration, everybody refers to the gingival outline. Of course, yes. Gingival outline is important, and we will see how to respect this area. At the same time, when you do veneer, when you select this kind of option to do veneers, at the same time, we have also a biological integration. Why? Because you don't remove the enamel normally. You keep enamel 100%, as much as you could. And that is really a kind of a biological impact, as an impact on biological integration, of course. Because, of course, you have prepared very minimally, and most of the time you don't do even anesthesia, just to let you understand how minimal is your preparation. So let me talk about this preparation of veneers in the chapter of biological integration, please. So I would like to show you how to be biologically compatible on the cervical area, so on the soft tissue, but also on the tooth structure maintenance. So preparation design. Enamel preservation is a key point. We start with the facial preparation, then we go through the incisal preparation, and then in some cases we go to the lingual extension, and we can prepare or not the interproximal areas. So that's all the characteristics and the features on the preparation design on veneers. So the key element is the preservation of enamel, as we said. Even if you prepare just the back side, or even though you go around and go preparing also the lingual part, the palatal part, anyway, our goal is that to save enamel, that to keep enamel, as you can see in this picture. So enamel preservation is a key element. So let me try to understand what are the doubts that you can have it in preparing teeth. The level of the gingiva, the margin, on the gingiva area. So can be supragingival or equigingival or subgingival, or better to say intrasulcular located. You can use a butt joint preparation for veneers, like you've seen here, with a very sharp line, or you can have an overlap on the lingual part of the palatal area of the incisor, upper incisor, having a kind of overlap. That is another solution. And then you can keep the contact point between the teeth when you prepare for veneers, or you can open it. And that is up to the case that you have in front of you. So that are the three choices that you have to select each time when you prepare teeth on veneers. The level of the gingiva, the level of the margin around the gingiva, the kind of preparation, butt joint overlap, and if you keep or open the contact points. So preparation design. Overlap preparation, you will have at the end a kind of path of insertion that is very similar to that of a crown. No differences. On the other hand, if you use the incisor shoulder or the butt joint, as you can call both ways, you have a really very easy preparation, very sharp line. And please incline the birth in the way you see now in the picture. Why? Because of course you can have also an horizontal path of insertion during the cementation procedure, and the lingual part or palatal part of the incisal edge that was cutted with this bad joint should be longer, should be visible from the frontal area if you want to have this kind of horizontal path of insertion. So that's the reason why you shouldn't use the burr in the opposite way. You should use the burr in that way you see here. So, preparation design, that is the butt joint, or butt margin, or incisor shoulder, you can call as you like it. In this case, you save tooth structure, because you don't prepare in the lingual. It's very simple preparation design, not complicated one. Less time consuming for sure, and especially easy reproduction on master cast. I want to add one more, that is also the path of insertion, that is multiple paths of insertion. Can be horizontal, can be even vertical. And that's really important to understand. So you have more advantages than disadvantages, in my opinion. That's it, the path of insertion. It can be horizontal, can be also inclined this way, even inclined this way. So you have a different kind of path of insertion, multiple one. So in our experience, we have seen that no difference are in the clinical observation between incisor shoulder, butt joint, or overlap. So today we use, since 20 years ago already, in 2000, I started to use the incisor shoulder. I was coming from overlap situation because it was a traditional prosthodontist, so the insertion that as a crown should be for me, it was for me a very good one, very safe one. But now, I started 20 years ago, as I said, I started to use the incisor shoulder. I never moved from that situation. So what about the preparation interproximally? Want to keep it or want to open it? That's the point. If you will not maintain the contact area, it means that you open it, you have the chance to modify tooth shape and contour. So remember, if you keep the contact point, you cannot modify the size, the contour, the shape. You are obliged to keep as it is. You cannot modify, I don't know, having the chance to have the two central incisors more dominant, for example. You cannot. In this case, if you have opened the contact area, you can modify the tooth shape and contour. In this way, you can also eliminate the interproximal defect and composite that sometimes happen to see there. Of course, the composite has to be renewed anyway before doing any preparation, but then you can cover the composite and overcome over the composite to the margin. And again, you have also, thanks to the fact that you can modify shape and contour, you can have an aesthetic improvement, an aesthetic optimization. And also a facilitating procedure for me, because again, you have the chance to use this kind of margin in an easy way. You can see the final margin. It will be easier. If you keep it, if you maintain, on the other hand, you have the sound tooth structure. Of course, you have to be sure that interproximal area are still completely healthy, not any kind of composite, old composite in between, no brownish areas that has to be opened in this case, because if you have brownish area with decalcification, you never know what happens next. So actually it's better to comprehend in this preparation opening the contact area. Tooth position and stability, of course, you can keep even without provisional theoretically if you want. And tooth structure maintenance. That's true because you keep tooth structure more than opening, but at the same time, if you open and you keep enamel 100% in the proximal area, means that you are still very, very conservative. If you have enamel 100%, for example, even opening the contact points means that you are still in very good condition. You have maintained anyway all the tooth structure, because if you keep enamel, you keep tooth structure. Let me give you this kind of picture. Let me show you this kind of picture that is not really nice for the people that use the traditional way how to prepare the teeth. Why I should put my birth in that horizontal way? It would be crazy. One normal prosthodontist, conventionally oriented, will never put their birth in this way. But I do, because in my case, this veneer will be prepared with the butt joint again, and I would like to have a path of insertion that is horizontal path of insertion. So I can put my burr in between the two teeth and try to extend my margin more in order to avoid to see the margin interproximally. That is one of the mistakes that I made at the beginning of my career. The margins were visible because I was using the burr just vertically, not horizontally. And vertically, if you don't want to touch the adjacent teeth, will stop you in the margin in a very buccal area. So it will be very visible. So now if you put your burr in this way, you can extend your margin more in. Of course, more in means that you don't have to go over the equator. As you could see, there is a red cross that's saying that don't do it, don't use the burrs in this direction. You don't have to go there. You have to stop at the contact areas, not going further the contact area. So what you should do is like you see here now, with the burr, with this kind of inclination. So be safe, don't do different than that. So let me give you an example about the case that you have in front of you. The patient wants to have a nice final outcome, want to have some veneers. But again, we have a look at the function of this lady, and the function seems to be not so good. Because when you move the teeth in front, the mandible in front, the patient shows that doesn't touch on the anteriors, only touching on posteriors. So this is a dysfunction. And once we have done a kind of occlusal adjustment in CR, we found at the end quite a big space between upper and lower anteriors. That has to be closed, has to be light contact, to have at least the starting of the anterior guidance. So we need to have some space that will be closed. If to do that, we cannot do just veneers. We cannot do just veneers, we can have to extend our veneers on the lingual part, the palatal part of the upper teeth. So as you could see here, we have the preparation that is within the enamel thickness. You see the dotted line in red is the dentin border, but we have prepared within the enamel. So we are really 100% of enamel around it. On the palatal area, we have not even touched the lingual. We have a space available. So you have not touched the lingual part. We have just added this ceramic that is bonded because it is etchable ceramic. Will be bonded. So actually, we have not touched even the dentin, and we have not touched even the enamel. So we kept exactly the enamel that was there because you have a space occlusally between upper and lower. So we call this a kind of extended veneer. We call full veneer. Full veneer. We have used in this case silica-based ceramic, that is etchable ceramic, and an etchable enamel. So we can create a kind of sandwich between two etched surface, one of the tooth with the orthophosphoric acid, the other one of ceramic with the hydrofluoric acid. So 100% of enamel with etchable ceramic. That is the concept of full veneer that gives to you great chance to create incredible aesthetic and function together. As you can see also in this picture, we have prepared the teeth, and I could say that is a quite old case. I try to be as conservative as possible, but I can notice that is some kind of preparation that interproximally was quite conical. Normally I don't do so conical preparation. But I kept enamel 100% because even interproximally, there was a lot of enamel. So that was said, that was checked before. On the lingual part, we didn't touch at all. We just refined a tiny bit. We kept the enamel that was present already. That was maybe 90% of enamel. We took the impression. So untouched enamel, we kept 100%. You can see from the whitish appearance of the abutment already etched that we have enamel 100%. It's easy to understand. And we are good. We are happy to know that we have enamel 100%, to be bonded the restoration the proper way. So interproximally, we have prepared a little bit. We need to have two surface, one tooth, another tooth. So the two parts are joined together. Joined together means that we need a space at least 0.5 millimeter of opening if you want to have at least 0.2 per side. I want to show you. That is the interproximal area. You see the thickness is 0.2. I'm worried about it? Not at all, because you have enamel 100%, so I can bond the restoration the proper way. But biologically speaking, coming back to the topic of today's lecture, the biological integration, I think is great, because we kept enamel 100%. And we have the chance to recreate a new kind of restoration, completely in enamel. 02 to 08, and that's the case 8 years in service. As you can see, it's completely still maintained. Biological integration is great because we had the chance to maintain the vitality of the teeth. At the level of gingiva, we can see that we have a really great kind of biological integration with the soft tissue that is just responding in a great manner 8 years later. Let me show another case in which we have some situation in which we have a kind of severe wear of the mouth on the upper and the lower, and we would like to finalize the case with minimally invasive prosthetic procedure with the MIPP. We did the mock-up. We are in occlusion here. We are in disclusion of posterior teeth through the anterior guidance. So we did the mock-up at first, and then we cut the mock-up accordingly to the thickness of restoration that we believe is necessary in this case. So we have to already have decided the material that we should use, and knowing exactly how much will be the thickness of the restoration that should be nice to have it. All this was done after having increased the VDO. It does allow us to keep enamel also in the lingual part that was untouched again. The back side on the left side is the view of the 6 upper anteriors with all enamel in every side. So we have 100% of enamel. So the key point, the VDO increase for the anteriors on the palatal area is that we have a full veneers concept again, because increasing the VDO, you have a space that was forming there, and you need to cover, and we emphasize the strength also of the restoration because we have new thickness there, about 1.52 millimeter, completely in enamel, if the enamel is still there, as it is in this case. So, final outcome, preparation of the upper and the lower, 218. You see how much was the preparation volume, is almost nothing. We have preserved completely the structure that was present before, that are mostly enamel, maybe 80-90%, the total enamel presence on the 28 restorations. And of course, on posterior area, we can have the chance to have some tabletops because you can increase the vertical dimension, of course, with the simple tabletop, with a thickness that is very, very minimal, like 0.3, like you see in the right side. And if you have enamel again, you don't have to be worried because that they will stick there without any problem. We have a lot of tabletop in place without any problem. But sometimes the patient wants to improve the color of the anteriors, and they ask for anterior area to be lighter than the original color. But then you need to increase the VDO, and you extend your case also on posterior area. And you can offer them to have some tabletop, that is the easiest way, and this is absolutely enough. But the patient then complains, say, why I cannot extend also on the back side this tabletop in order to match the color that we have selected on anteriors. So that's the reason why from tabletop many times we build up a kind of buccal occlusal veneer. That is this kind of restoration. So it's a tabletop that is then extended to back side, probably without preparing most of the time. It's just very minimal preparation, as you could understand from this picture. You see that is enamel 100%. So it's an extension from tabletop to the buccal in order to match the same color that we have selected already for the anteriors, that maybe were worn out, as you have seen in this patient. So we needed to cover and to increase the VDO on the back area. We increase the VDO, we put some tabletop, but then the patient say, no, I would like to have not the tabletop, but something that covering also the back side that are maybe brownish, yellowish. I want to maybe be white 100%. So without preparing practically nothing or almost nothing, we can have this kind of bow, buccal occlusal veneers. The insertion is still very good, can be even occlusion, even vertical, but mostly oblique insertion. Path of insertion should be more or less like that. Okay. So what you see here is not the preparation on the lingual part, extended on the lingual, but just having the chance to increase the VDO to see the thickness on the palatal area, most related to the increase of VDO. So looking from this picture, you could see that are tabletop or both, you don't know. You have to see the buccal side in order to know if you have a tabletop or above. That's the lower arch, again, the increase of VDO, allow you to see there is no thickness from the lingual, but did not prepare the lingual area. You can see, thanks to that we can achieve a good result in terms of finalization, final outcome, with the full veneer on the upper arch anteriorly, with the normal regular veneers on the lower arch anteriorly, of course, and on posterior area, tabletops or buccal occlusal veneers. In both cases, you increase the vertical dimension, and you can extend buccally the aesthetic result with above, with buccal occlusal veneers. You see, the lady has some brownish area, yellowish on the back area, also in this area here. And that's the reason why, from tabletop, we decide to do this kind of buccal occlusal veneers, upper and lower. Anteriorly, again, very nice integration from an aesthetic point of view and also from biological point of view, as shown also by this picture, 1.5 years after the delivery, showing very good maintenance. So we discussed about how to perform biologically in the better way, the best way, talking about not just the gingival margin, but also the tooth structure maintenance. And that is, again, a kind of very important step on biological integration. Biologically, you have avoided to prepare so much, you didn't have any injury on the pulp, you still maintain the vitality 100%, the patient is happy, and the mouth of the patient is very happy. But again, traditionally, as you said, we should count that the biological integration is normally referred to the gingival outline. So that's the reason why now we'll investigate how to keep a good kind of healthy status for our gingiva. First of all, I would like to divide the two preparation modality in two different parts. Intrasulcular and subgingival. In my opinion, they have two different kind of explanation about the two titles, the two different written titles. We believe that intrasulcularly you can go with my burr even inside the sulcus a little bit, at most injuring the epithelial attachment but not touching the connective tissue attachment. In the subgingival area, as you can see on the histologic step on the right side, you see that there is some redness on the area where you have achieved, extended your preparation up to the connective tissue attachment. Because in this case, you have an irreversible response. It will be the nice response still if you keep your margin within the sulcus, having at most touch the epithelial attachment, but when you go to the connective tissue attachment, you have a kind of reaction that you see in this clinical picture, because you are going to the subgingival margin. Subgingival, again, meaning attaching also the connective tissue attachment, injuring the connective tissue attachment. So, reaction for these will be different each other. So the attachment violation means that you have an individual response, negative response. Yes, in the right picture you can see a lot of plaque accumulation. That is, of course, creating even more problems. But at the same time, you see that this kind of insertion of the restoration were very, very deep into the sulcus, going to the connective tissue attachment. That's the reason why. So this is a very classic, a very well-known article by Gargiulo, the first in human, showing that normally we have a very shallow sulcus, especially in the anterior area. In the Gargiulo article, it said that you have a very also standard variation, very much standard variation on this area. But actually, what you could say, that you cannot generalize saying that 0.7 is the normal depth of the sulcus area, because you have to consider that the buccal area is different from the interproximal area and from the palatal area. On the buccal area, you normally have 0.5, 1 millimeter at most of sulcus depth. I'm talking about a healthy situation. But if you go to this interproximal area, easily you can go up to 2 millimeter, even 3 millimeter is still considered a physiological one. So, again, don't go with your preparation up to this area. This area is the connective tissue attachment. Keep on this area here, the sulcus area. At most you can touch a little bit this epithelium attachment, but please stay here. That is a must. But never go this, never go here, because when you go here, you have vessels and you start to have a reaction, inflammatory reaction that never go out. So if you map the sulcus depth as first, you can have the chance to understand exactly what you have to do. First step is facial sulcus depth is 0.1 millimeter. That's normal. If you have more than that, seems to be not the good number. Maybe there is something wrong. And in the palatal interproximal area, the sulcus depth goes from 1 to 3 millimeter, being still physiological one. So now the question is from everybody, how much you go into the sulcus? And the answer is easy. The healthy crevic is very shallow and generally varies in depth from 0.5 to 1 millimeter on the facial aspect. That's very classic article, long time ago. And actually, they said the truth. They said, very, very shallow that sulcus depth. So what to do? Normally what we do is that in the healthy sulcus, the intrasulcular preparation depth depends on the amount of temporarily gingival retraction, or better say displacement, achieved by a gentle insertion of a cord, of a retraction cord. So, let me better explain this kind of concept. We prepare, you have used the metal ceramic work when you use opaque material. Today with the porcelain that are very transparent and translucent, you can also avoid that. But classically, we try to go into the sulcus to hide the restoration. So let me tell you what will be a potential risk on that. Now you see the burr that is inside the sulcus. And we said we could stay inside the sulcus without creating any problem. But anyway, you have dangerous because you can not be able to see all the sulcus depth everywhere. And maybe with the burr, you take a risk to go too deep and maybe to touch the connective tissue attachment. And especially, you have in this case an apical extension, dangerous one. And at the same time, with the same burr, you can have also the chance to use, not in the proper way, maybe touching the internal part of the sulcus area too much. In this way, having a lateral extension, horizontal extension. That's dangerous too. So two main risks that are present there if you go with your burr inside the sulcus. But now the question is, yes, but if you want to cover your margin, you need to go into the sulcus. Yeah, but the answer is, do you really need to go into the sulcus with your burrs? Cannot be possible to have a margin that is intrasulcally located, but you never went underneath the sulcus. Within the sulcus, we have stayed outside the gingival outline, at the gingival outline, at the equigingival level. That's the question. Let me show you. Apical extension here. We go into the sulcus, we go deep into the sulcus, but be careful. If you go too deep, you can maybe touch the connective tissue attachment, and then you can damage them, having a kind of irreversible kind of inflammation. At the same time, the risk is also to touch internally this area here, the internal area here, and to have this kind of problem on lateral extension. So, apical extension. Let me highlight this area here, and you see that more you go in, more you take a risk to have inflammation after that. So, just to summarize, sulcus area is this, and then you have the epithelium attachment, and then the connective tissue attachment. We should work on this area here, within this area. Then you could extend a little bit here, but will start to be dangerous. But please never go there. This is a redness area. So, also in this histological situation, you could see you have a gun in your hands, very dangerous. You can become very dangerous if you use this gun in the improper way. Big burrs inside the sulcus. Please don't go to apical here. And please don't go to lateral area here, because you have some vessel there after initial epithelium. Then you have some vessels inside. So be very careful using that. And I believe there is a way how to be as less invasive as possible during this kind of procedure. So you have lateral extension now. And again, be careful. If you touch with this burr, you go directly to the internal part of the sulcus area, and then the thickness become smaller, and you arrive to the vessels. You have a reaction, and you have a recession. So be very careful on that. So now, let me go back to preparation, how to avoid all this potential risk. We prepare at the marginal level. If you prepare at the marginal level, you don't take any risk to create any kind of problem of the gingiva. You don't touch the gingiva. So that's the preparation we made. Then, after this preparation, we could go into the sulcus to do the intrasulcular preparation, but we don't want to do it. We want to achieve the result to have a crown, that is the crown restoration, that is you can hide the restoration inside the sulcus without having prepared inside the sulcus. That is what we would like to achieve as a result. So we don't go into the sulcus with the tooth burr, with the burr. We want to prepare at the marginal level. We use a probe to understand and to map the sulcus depth, and to understand the tone of the soft tissue. That should be absolutely the good one, because the prerequisite to have a good result at the end is, of course, the healthy situation of the gingiva. So no bleeding on probing. So connective tissue tone is requested, of course. You have no bleeding on probing. And now we want to do the impressions. I would like to talk a little bit about the materials, but then you go back to the technique, how achieve the result we wanted to hide your restoration inside the sulcus. So the pressure material that you can use are normally vinyl polysiloxane or polyether. And we normally use heavy body on the custom tray, a light body on the abutments. So it's called the technique one-step double mix technique. It is the one that should be used, I believe, in every case. After having built up yourself a customized tray, or maybe your technician, but I do it myself in my office. So, vinyl polysiloxane, polyether, both of them are great. And actually, it's the best for literature review. is the fluidized material inside the sulcus, a gently air dry on abutments. And then we have the more viscous material that is on the EV that allow the penetration of the light body into the sulcus area. That is what we're going to do. So suggestions: individual trays for big cases, adhesive inside tray, then weight, of course, disinfection with 2% of glutaraldehyde or 5% of hypochlorite for 10-15 minutes. That's all the necessary knowledge we know, actually. We can use both polyether, we can use a kind of combination between polyether and vinyl polysiloxane that I found a very, very good one. That's the material that I'm talking about. It is called Identium. EV body, light body, is again a mix from polyether and vinyl polysiloxane. What is interesting, how much time you have for the working time. Polyether is double time than vinyl polysiloxane. So if you have the big rehabilitation case like this, the full mouth rehabilitation, polyether guarantee you more time, more working time. And that is something important. Even the Identium will do the same. But vinyl polysiloxane is just 1 minute. So now you have all the material that we have selected to send to a dental technician. 4 impression materials. Why 4? Because I prefer to use double impression all the time. In hours of our work on this patient, what is the means to use 5 more minutes to have another impression? Nothing. It's just great, because maybe sometimes it happens. The second one is better than the first one. Maybe you have a little bubble in one part that is not possible to see the other one. So you can use maybe another abutment, another store models. It's up to you, but 5 more minutes is nothing compared to the many hours that you invest in this case. Then you have the Facebook, all the bite records, etc., etc. So impression taking. Again, we want to keep my margin. I want to keep my margin at the gingival level. The technique I'm using in this case is one chord technique. I will explain to you how we do it. So as I said before, we want to avoid to go with our burr within the sulcus. In this case, our choice was that to keep the margin at the level of the gingiva. And that, for example, is our normal clinical choice when you do a kind of full rehabilitation, and we prefer to have these margins at the gingival level, for example, on posteriors, on molars, or even on bicuspids sometimes. Then, one cord is needed. Preparation is made at the gingival crest. Then we put the cord, and the cord size should be the one that allow you to press the cord gently, having some little displacement, apical displacement. We don't call it normally retraction, because retraction has a negative sound, in my opinion. So displacement, apical displacement, that is temporarily displaced, because if the tissue is an healthy soft tissue, then when you remove the cord after a while, the soft tissue will collapse down to the original level. That's the point. So now you have a supragingival margin, apparently. And now is the time to take the impression, because the technician can read easily, because he can see a supragingival margin, even though we know that after cord removal, when you have taken the impression already, after cord removal, the soft tissue will go back to the original situation, coming back the equigingival level now. No more supragingival, but equigingival. So this is what I believe is ideal for posterior areas. Then, if you want to put your margin in the intrasulcular area, we normally use 2 cords. Same stuff like before at the beginning. Preparation of the gingival level, so we don't touch the gingiva. Then, we put a cord like the first case that we have seen before. So, the margin becomes supragingival located. We have not touched the gingiva at all up to now. Of course not. Next step is the following. I re-prepare the teeth to the new gingival level that, as you know, is already apicalized by the cord. The cord was pressed, the soft tissue was going apically, and now we have the cord that, now we have the preparation that are recreated, re-prepare until the new gingival level. But the new gingival level is temporarily apically displaced, retracted in some way. But then we said when you remove the cord, the soft tissue collapses down to the original situation. We'll see. Now, why to use the second cord? Not to push the first one more apically, not at all. Only to enlarge the sulcus. So with the first cord, we have some apicalization of the margin. You can see some recession, and now we prepare with the burrs, as you could see, to reposition the first margin more apically. Preparing like that, as you've seen already. Now, the second cord, as I said, is positioned on the sulcus in order to enlarge the sulcus depth. We add some chemical, like Hemodent, for example, that is aluminum chloride 21.3%, that maintains some enlargement for a few minutes. So, you know the limit of these two materials, vinyl polysiloxane and polyether. They are both great material, but one limitation is you have not a very good tear strength. The tear strength is quite poor for both materials. So sometimes you can see some little part of impression that was broken within the sulcus. That's quite classic. So in this case, with the second cord that is a bigger size, you can enlarge the sulcus, also thanks to the chemical, having a larger sulcus width. That is what we wanted. Now, the second cord cannot penetrate completely on the back side, as you can see from this area here. You see, you have the second cord, the bigger one, with in the bluish, that is not completely inserted. We don't want to push too much. We want to just enlarge the sulcus. So, we are not able to go deeper. The sulcus depth is shallow, as you said, 0.51 millimeter. So, what else? Now, we remove the second cord. Remove the second cord and automatically we take the impression. The first cord remains in place. We see that we have a larger sulcus width right now, as you could see from this area here. And we take the impression at this point. So, let me summarize to you. Preparation extrasulcular located. Okay? Extrasulcular is the preparation that we have done. Never went inside the gingiva. So we cannot damage the gingiva. We cannot be biologically not good enough because we have prepared the teeth only extrasulcular. The only fact is that once you remove even the first cord, the soft tissue collapses down to the original level. As you could see, becoming automatically from ecogingivally to intrasulcularly, even though you never put my burrs inside the sulcus. But just because we retracted the cords, the soft tissue with the cords, and now the soft tissue, that is of course healthy, going back to the original situation. So that is the mechanism. So we prepare inside, and you see, once you remove the provisionals, you can perceive that the preparation are underneath the soft tissue is within the sulcus. So the crown margin is intrasulcular located. Even though my preparation were just at the gingival area, extrasulcular, but my margin at the end, it will become, again, as I said already, intrasulcular. It's almost magic, but it happens. It happens many times, especially with the big cages. Look at this situation. Once you remove the provisionals, you can easily understand, that you are into the sulcus, everywhere, even palatally. Most of the time that we don't need to go palatally in the sulcus. We can be supragingivally, but where we need it is on the back side. And remember, the height of this sulcus is very shallow. So let me show you a case before and after with the preparation design, with this kind of a design that you discussed, with the two-core technique, upper, lower. So we have 28 restorations. You can understand that we are very predictable in what we do. It is a consistent and a predictable technique that can be achieved. You have no one that is visible, so we are all in the sulcus. It means that we have a biological integration, but also an aesthetic integration. That is what we really believe that is important to achieve as a final result. So the biological integration at this point is together with aesthetic and function, and this way we can achieve a very good result in terms of final outcome. So just to finalize, to summarize what we have seen, of course, we focused before about the finalization of our final rehabilitation, extensive rehabilitation from the aesthetic impression technique in a proper way. But not just talking about the biological integration on soft tissue, I was saying, but also about the two structural maintenance. That's very important too. That's the reason why we discuss about preparation design, that today, if we could, we try to prepare as much as possible with a conservative way, keeping as much enamel as possible, and being really, really conservative. That is what we really believe today to be achieved. So, integration from the aesthetic, function, and biological point of view. Thank you for listening to me, and I'm sure that we will meet again in another lecture. Ciao.